talk about CTO complications. So what we could have, we do CTO PCI. We could have main vessel perforation, distal vessel perforation, collateral perforation, donor artery injury like dissection, thrombus, air embolization, or aortic root dissection, especially when we use LA1 for the right CTOs. Let's talk about perforations. So we could have a main distal wire perforation or collateral perforation. If we have perforation, we should do balloon tamponade right away for stop the bleeding first of all, and we should give some intravenous fluid or pressures. And if the patient has hypertension, then we should do a pericardiocentesis right away. And also, of course, we should notify surgeons that we have a perforation. If there is no extravasation after for a while, then we should monitor patient very carefully. I will show you an example how important to monitor patients. Or we have or if it's still bleeding, then we have to treat cause. If we have a large perforation, we have to implant covered stent or try prolonged balloon inflations. Sometimes it works. Or if we have distal embolization, we should do coil fat embolization or thrombin or thrombus embolization. And also I like to talk about cuts per balloon embolization. I'll show you one example. This is how we should treat main artery vessel perforation. After perforation, we should right away balloon tamponade here, and after that we should leave in place this balloon as inflated, and we should insert a second guiding. It's better, and should send a second guiding wire, and over that the second guide wire we have to inflate another balloon, and we have to remove the first balloon and insert the graft stent, covered stent. This is the best and safe way to deal with the main vessel perforation. So in that case, we don't lose any time and we don't have any bleeding. If we have distal perforation, we can do coiling or other things. I'd like to share with you one distal perforation. That's after CTO recanalization. You know, if we use hydrophilic wire, we have to be extremely important. So if we use hydrophilic wire, we have to be extremely careful. For example, this is pilot 50 at the distal PLA. You know, during the bifurcation, our wire is looped and went very deeply. And after that, we see that we have a perforation at the distal. So this is very important. When we deal with the hydrophilic wire, we have to make sure it's not knuckle at the distal. This is very important. So how can we treat this? Yes, we can coil this, and also we can try before coiling or do anything long balloon inflation, and sometimes it could work. In here, it did work. I'd like to show you this. So after long balloon inflation, we don't have any more bleeding, and of course we have to very carefully watch this patient in the CCU. Another patient, this patient is very interesting to me. I like to share with this. You know, this patient belongs to my colleague. So they try to open, you know, high OM, and they stent it. They don't like the result. They have seen some plaque at the left main, and they put another stent at the left main. And you know, they work. Please look at it that the LAD wire is now in the distal LAD, but while they're working, wire went somewhere else. It's in the very small branch, diagonal branch, and it's already knuckled and very deep. They didn't see it yet. After they did everything, kissing and everything, they see some you know, contrast here, but they think it looks okay because there is no any bleeding, there is no any pericardial effusion. They send the patient to the CCU, and after for a while they checked it and they did kissing. After 2 hours, patient became hypotensive, and they see that there is a perforation, obvious perforation, and they did coil it. That's fine. After coiling, everything looks fine. But please look at here. There is some kind of endocardial damage here. They are very happy with the result. There is no any more bleeding, and they sent patient to surgery. After for a while, patient has, you see, please look at here. And after 90 minutes, patient had, a pulseless VT, and they did CPR, and now they have a proximal perforation. It's very severe, and they did another coiling, and after the second coiling, there is no bleeding now, but they have still having some blood from the pericardium space, and heavily drainage, and they are very confused. There is no bleeding, but still they have lots of blood from pericardium. And then they did, they tried to close the diagonal. I think it's not necessary, but they did it. And then still they have bleeding. So what's the reason? They have still, free bleeding, and they checked the RCA because they did some RCA work before, nothing. And they thought that they are in the right atrium, maybe, right ventricle, but it's in the pericardium. So they called me in that time, and I told them, please send the patient surgery. And the surgeons saw a hole done by sheath for pericardial pericardiocentesis. So it's to me, very interesting case. How can we see that late perforation? Mostly wire perforation present lately, but this is something else. Another case, this patient has distal perforation again, LAD CTO, and looks okay after PCI. Patient sent the TCU, but after that there is a distal perforation. There is a pericardial effusion, and at the moment it was the live case from one of our meetings. And after that, we see that the bleeding. And what we did here, we embolize cut balloon here. 2 cut balloon, seal the, occlude the vessel, and solve the problem. So I'd like to share how we do it in 1 minute. We cut the balloon at the half of the body, and we load this balloon over another balloon, monorail balloon, to send this balloon to the distal of the vessel. Now I insert the balloon, and I insert this cut balloon over that balloon. This balloon. So it's on the wire now, and I bring it to balloon. So this balloon will bring this cut balloon at the distal of the main artery. And when I these days for the distal part, it's really cheap. We also use, of course, coils for epicardial collaterals, but for distal perforation, this is very helpful. When we inflate the first balloon, cut balloon stays at the distal. When we remove it, that wire, the balloon stays there. So epicardial collateral perforation is really issue. We have to treat both and mostly. Septal is okay most of the time, but still we might have a problem. We have to watch very carefully. In here, for example, we have a small perforation, but for a while, and after 10 minutes, it's increased, and 20 minutes even it's increased bigger. So in that case, it shows me that we have to occlude this collateral, and after coiling, there is no any more bleeding. Epicardial collateral. This is a CX-CTO patients. We failed to open this artery antegrately, and we think that we can open it from the retrograde. And you see there is a nice collateral from here after tip injection. We see a collateral, and actually CO3 easily crossed that collateral without any friction, and also our macrocatheter crossed it, which was fine. After work, we had bleeding, right? So both hand, in that case, we ruptured the epicardial collateral. To seal this, we have to coil in both side with diagonal side and also distal CX. So we brought macrocatheter, distal OM first. We coiled. We did this perforation during the live case. Unfortunately, OM side closed, and after that, CX also coiled with 2 more coiling. This is the final image. So what we have, we could have also donor vessel injury and complications like dissection, plaque disruption, thrombosis, or air embolization. In that time, we have a large territory at risk. We might have extensive ischemia, hemodynamic collapse, immediate intervention required. We should do, we should implant a stent, or we should give, some fluid and pressure if needed. This is very urgent situation. We have to be very careful for thrombus. ACT should be around 350 and more. That's very important. We have to check every 20 minutes. I'd like to show you one very interesting complications, Amesh, if we have time. It will take 2 minutes more, but it's very interesting complications. This is RCA CTO. We see that we have a nice collateral, for, epicardial collateral, ipsilateral collateral, nice one, and we failed formantigrately, and we thought that we can open it retrogradely. You see that the wire crossed nicely, very nice. Macrocatheter crossed very nicely, nothing wrong. We did reverse cart here, that's fine. And I did what we did, that we had a loop wire here. So, but we did only RG guiding here. So we use only one guiding. That's our problem here. So we should do ping pong technique, and I do ping pong technique now after this case for all my cases. I try to, I did some dilatation. You see that we have calcification there, and it's ruptured. This balloon 2.5 ruptured, 3O ruptured. After 3O ruptured, we couldn't remove balloon. It's trapped there. That's not a big deal, We can do jail that balloon there. That's okay. What we have happened, our RG wire twisted itself in the RG guiding catheter. It's twisted all the way. So when I try to open it, it's twisted more and squeeze the heart. All right. So we did have tamponade in this patient, dry tamponade. Blood pressure was 50. It was terrible situation for me. We could do nothing. We called the surgeons. They said that this is post-CABG patient. They don't want to touch it. They didn't want to touch it. So what we did at the end, because patient suffered, he has severe hypertensive. And what we did, after sending another guiding, I pulled forcefully one end of the RG wire, tried to break the wire, and I broke it. But of course, I ruptured the epicardial collateral, ipsilateral collateral. But that's fine, because it comes from the proximal RCA. We did graft at the proximal, and we seal it. This is one of my worst complications in my life. Patients suffered, VR suffered, but surgeons can't do anything. It was very terrible situation.